Nuevamente, buenos días a todas, a todos. Bienvenidos a esta tercera conferencia internacional en Imagenología molecular. Una bienvenida muy especial a quienes vienen desde distintos puntos del país y muy especialmente a conferencistas regionales e internacionales que están participando de este tercer encuentro. Ni que hablar que contamos con los fundadores de esta técnica aquí en la sala, la bienvenida para ellos de manera muy especial. Ni que hablar que ya vamos rápidamente a darle la bienvenida a quienes integran el comité organizador de este tercer encuentro, doctor Eduardo Savio, está la doctora Patricia Oliver y María Emilia Ungo. Vamos a invitar también rápidamente a quienes actuarán como moderadoras, moderadores en la primera de las conferencias y los vamos a invitar a que se vayan ubicando rápidamente allí en la mesa que está sobre el escenario. Doctora Graciela Lago, doctor Mauricio Cuello, bienvenido. Muy bien, ya están ubicados quienes van a actuar como moderadoras, moderadores en la primera de las conferencias, pero antes que nada, palabras de apertura a cargo del director general del CUDIM, profesor doctor Henry Engler, a quien damos la bienvenida.
Dear authorities of the Uruguayan government, ladies and gentlemen, Mr. Chairman, Graciela Lago and Mauricio Cuello, welcome to the third International Conference of Molecular Imaging, when we celebrate also the 5th anniversary of our center. We have today a group of very distinguished researchers in molecular imaging coming from different countries. I will not talk about neurodegeneration today because I want to honor some of the most important pioneers in the development of the PET technology. We can't forget our roots. These researchers have accepted to be here, and for us, they represent an example to be followed. The title of my brief presentation was Quo Vadis CUDIM? Where are we going? The answer is, we hope CUDIM will follow the steps taken by these pioneers. We want to emulate them, but we also promise to think with our own brains and go ahead guided by our convictions. They have showed that impossible things only take little more time than the difficult things to be performed. This is the way we definitely want to work. They have introduced the basis for the novel imaging pathology, and we will work to try to develop this concept. I will introduce here Professor Alavi, who received his medical degree from the Tehran University of Medical Science, 1964. He has worked at the Albert Einstein Medical Center, the Philadelphia VA Hospital, the University of Pennsylvania, and the Beth Israel Deaconess Medical Center. He joined the University of Pennsylvania School of Medicine 1971. He is professor and director of research education in the Department of Radiology of the Hospital of the University of Pennsylvania in Philadelphia. 1973, together with Dr. Kuhl and Dr. Martin Ravich, in collaboration also with Johanna Fowler in Brookhaven, They conceived the idea of labeling the oxyglucose with fluoride 18. And this led to the development of FDG. In August 1976, became the first to administer FDG to a human being. He has many awards and distinctions, and he has more than 1,000 publications. 2004, he received the George Charles de Hevesy Nuclear Pioneer Award. Professor Bengt Langström is Professor Emeritus at Uppsala University. He has over 30 years experience in the synthesis and applications of the PET radiochemistry. He was director at Uppsala University PET Center. He is director of the Benker AB in Uppsala, Sweden. He is professor at Imperial College of London and the University of South Denmark. He has more than 350 papers published in chemistry journals and over 550 in life science and medicine. He has several awards for his research. 2001, his team in Uppsala labeled the 6-hydroxybenzothiazole, and he gave the molecule the name of PIB. In 2010, he received the Nuclear Pioneer Award from the Society of Nuclear Medicine's George Charles de Hevesy for his contributions to the nuclear medicine profession. And he is my mentor, and he is the CUDIM's grandfather. Professor Mats Bergström, educated in mathematics, physics, and with a PhD degree in medical physics, Professor Bergström participated in the building of one of the first PET cameras at Karolinska, Stockholm. Moving to Uppsala, he became head of preclinical laboratory at Uppsala PET Center and GE Healthcare, Sweden. Then he spent 2 years as director of PET program in Vadis, Basel, Switzerland, followed by 2 years as director, head of biology, lead imaging scientist in oncology, Clinical Imaging Center, GSK, London. He moved to Basel, where he performed as senior imaging expert, imaging science at Roche, Switzerland. And Professor Jorge Barrio. Professor Barrio was born and started his education in Buenos Aires, Argentina. He is professor of molecular and medical pharmacology at the University of California, Los Angeles. He chairs the university's medical radiation safety and radiation drug research committees. He has searched for identifying and tracking brain chemicals and pathological markers in vivo. This has resulted in a number of important findings relating to Parkinson's and Alzheimer's disease. The first PET study on the visualization of plaques in the living brain of an Alzheimer's disease patient was selected Image of the Year 2001 by the SNM. He has more than 200 published journal articles reporting his findings. So we need to say thank you for your formidable contribution. And I will leave now my place to Professor Bengt Langström. Thank you very much.
So, first of all, I wasn't aware that I should give a talk already now, but Henry wanted me to give some perspectives in the beginning of the conference as well. So, first of all, I like to say to Henry and the CUDIM ship that good luck and best regards on the future journey, because there is a journey and we're just in the beginning. We might not have even left the harbor yet with the PET technology. And I like to, if I can manage now, sorry. No. Here. Okay. So I think the theme of this conference will be around issues related to neurodegeneration. And I think there will be some exciting discussions because there is a lot of opinion about neurodegeneration and how to use molecular imaging in order to understand what's going on. And just to give you a cartoon of events which might take place, you can see that the formation of plaque, there is the nicotinic receptor, it's the tau formation, it's synaptic failure, which gives reason to cognitive impairment. That's just a few of the components which might be here. And when Henry asked me to give a contribution, I decided that I will take this because we're just starting up a project with funding from the Swedish Strategic Research with the concept of developing biomarker for the AD concept or the neurodegeneration. And we will look into the whole perspective of this because I think there is, FDG is a great tracer, but if it stops with the PET in the FDG, I think we are not utilizing the PET technology for as good as we should, at least from the research perspective. How far it will go into the clinical, that's a different story, and it will depend on how we are developing technology. The PET technique as it is today is a quite expensive technology. As you see if you go to the very great facility of CUDIM, it needs very, very special resources. It needs a lot of different resources, and it needs that these resources are communicating very well. So there is a lot of challenges in that. I will talk more about that tomorrow, I guess. So when you look into the concept I will discuss is that neurodegeneration is not an event just happening, it's a time perspective. And I think it's quite clear that we need most likely to have several molecular probes to prove what's going on, and it probably differs from individual to individual. So I would like to say that the journey for CUDIM and for the whole molecular imaging field is to go from seeing nice pictures to understanding what is creating the nice pictures. I think that's an important message. And many years ago when I started, we were often using the wording, a picture tells you more than 1,000 words. I would like to rephrase and say, a picture might tell more than 1,000 words, but please remember, with 1,000 words you can tell many stories. And if you just take one word with 5 letters, 5 letters can constitute words with different content. So I think it's important to understand we need to take this step from just seeing images to the concept of understanding images. And I have been in CUDIM now discussing with Henry several times, and I realize more and more we have some important tools molecular imaging tools, but they have not been understood as good as they should before we start to do the interpretation. No, that's the way. So this is just an illustration. A number of different tracers in the field I was talking about. We can look into astrocytes, we can look into microglia, we can look for the plaque, which has been the PIB and the story. And I must say that I was part of the development of PIB. I still think that there is a lot of work to be done before we can make the type of interpretation which we do now. So I think it's time to be self-critical and being humble about the tool we have, and we have to work hard in order to understand what are the tools really telling us. So I think I look forward to this discussion, because we have different opinion, and that's the beauty with science. We can have different opinion, we should have different opinion, and we should be allowed to discuss them very open and have ideas to go back and do the hard work later. So these are just examples. There are new tau marker coming on the table, and all of them are, again, single molecules which we have been using, and it reflects something, and the background for the information to these images are still quite scarce, I would say, because things like this might happen. You have a genetic interaction. And here is an example using PIB where we have an AD patient with an Arctic mutation. It doesn't behave the same way as some others. So be careful out there. We know that there is a discussion about FDG-PIB. We will have this discussion here, and it's always very healthy. They are describing different perspectives of this process. And if I'm really frank, I would say, and we don't understand none of them. We are underestimating. But there is a message already now saying it can be extremely valuable if we just continue with trying to understand what the picture content is, not what the picture looks like. So I will just give another example, which is the type of starting scenario for this project we are starting now. So we have been using multi-tracer approaches and using principal component analysis to see if that could be a way to improve the way the clinical decision could be made. So these are data from using PIB, deuterium deprenyl for astrocytes, FDG for glucose transporter expression. And if you put this in a number of patients and you do a PCA analysis, you can see that you can subgroup them. The symptomatic carrier, sorry, I'm not in good shape with this. Symptomatic carrier, the MCI patients which are positive in PIB, or the MCI patients which are negative in PIB. So with a combination of tracers, we can very, very much distinguish between these groups. And that gives maybe the story that the neurodegenerative process is not identical in all individuals. So that is one of the issues, and that even amplifies the fact that we need to do more. So we have been starting out a different approach here to use in silico calculations. And the idea was that by using different type of probes, we can do a fibril probe, membrane probes, DNA probes, metal probes. So now we can approach this with different tracers from a theoretical perspective. So what we have been doing then is doing in silico modeling, and here is an example where we have been using fibrils, in this case 5. We have been looking on various type of molecules and how they bind using in silico measurements. And of course, the in silico measurements is not giving all of the answers. It's actually giving very few answers, but it can give you other angles on the problem. So the idea is that you take your molecule, you have this protein structure, and these are protein structure we can run in a computer if we have a good computer with some power. And we can locate binding sites. It will be very hard to understand what is regarding K on, K off. Because you should be aware, very often in the PET field we talk about affinity. And affinity is a ratio between K on, K off. So there's a lot of examples out there, not in the neurodegenerative field, but in other fields, saying that, okay, you can have the same affinity, two molecules, same affinity, but they behave very, very different because the K on, K off are different. So if you have a affinity of 1, it can be a K on, K off, which is 1 to 1, or it can be 1,000 to 1,000. And these are the rates, or it could be 0.001 to 0.001. So these are the points we need to understand more. And so far, the PET field in general are still looking on the images. And I think this is the challenge we have. We need to go to a next level. We intend in any case then to use such probes and see if we, by starting with the leads we have today, and there are some leads out there, and look for what type of modification should we be able to do in order to understand more of what's happening in vivo. Because I think the point is to emphasize the biggest beauty of the PET technology is the fact that we can do in vivo biochemistry, which then now and then can be interpreted from pictures, images. But it's the quantification and it's the in vivo biochemistry which is the important thing. So we have started now by just looking for fibrils. As I said, we can add fibrils, we can start to do calculation, we can compare molecular structures and see if they are different or if they are similar in the binding. We can't distinguish if there is a difference in rates. So that is the reason why we need to have this integrated into experimental setups. We need to do preclinical validation of this information. But at least our hope is that we should be guided better instead of just looking at images and not understanding the molecular part of it. The point with some of these compounds is, of course, that some of them are fluorescent, and you can use optical information also in the experimental settings. Our intention is, however, to do PET tracers. So this is an example. So this is an example using this thioflavin T compound, which is, by the way, then a model for the PIB, the PIA, and so on. And then you observe there are at least 6 different sites which has been falling out from these in silico measurements. And the interesting thing is that some of the sites has been identified earlier, but because we are building up now fibrils, maybe we can go up to, I don't know where the limits is, it's probably computer issues. But then be aware of that the fibrils are not the plaques. The plaques is precipitated fibrils, so they're much more complicated. So this, I think, is some of the concerns. I think the information which is important is that you can bind either in parallel or you can, sorry, I have 2 big fingers for this one. And it's important to realize that this binding can be internally or externally on these fibrils. So this type of information, I think, is important. And of course, we can also look for optical properties when we do this. And we can learn, for example, what happens if we add water, if we had other competing compounds. That will change some of this binding to the fibrils. So that's another issue where we can maybe improve information in order to set up the preclinical experiments more careful. So here is an example where an observation of a membrane probe showing that there is a red shift in the fluorescence. And why is that when you put it into the binding scenario? We don't know yet. Can we understand it? Could that be a way to explain some of these interactions? These are data which we then are continuing by using, so this is the PIB, this is the AstraZeneca. This is the AstraZeneca compound, and the only difference, you could say it's no difference, but it's a big difference. It's a nitrogen in this structure, so that means you're changing not only lipophilicity, but more, you are changing PK. And we don't know what's happening in the binding scenario. We don't know if there could be a minor pH change, local pH change, which could explain things like that. So I look forward to all these theoretical calculations. And the idea is, of course, we will look for a lot of these compounds which has been out there, and we will look for, if we modify them, what are the consequences. The other issue here is that when we go back to the first slide, it's a complex scenario with a lot of biological processes which might take place. And some of these molecules might actually act on several of these issues. And this would be also another reason why we like to continue, not only on the fibrils, but we like to continue, go back to the cholinergic, because that's where, at least from my perspective, our perspective, we started with cholinergic functions even in Alzheimer. And I was very pleased when I was actually preparing a lecture for next week, and I went back to my drawer, going back to 1978 or something. It's a long time. 30 years, I feel very young then. It's much more than 40 years. But anyhow, so this is actually a picture just by labeling nicotine, but the two enantiomers on nicotine. So this is actually a publication which I then remember. So you make R-nicotine, S-nicotine. This is in Alzheimer patients. This is the baseline. Then we did tacrine treatment, and after 3 weeks, especially the R-nicotine changed completely. We don't understand this. I mean, it certainly is not related to receptor binding only. There are other processes going on here. You can say we did also in this case FDG. This is the treatment, and there is an impact. So maybe this is just an impact of the fact that we have stimulated the brain. But I think this shows the point that we need to understand more what these molecular probes, the type of information these molecular probes gives us. So now, since we have access to the structure of cholinergic receptor, we will use the same type of approach, go back to that, and then we will run it through. So the whole project is now related to the fact that we will do this virtual screening technology in order to see, are there common denominators? Could it be reasons why we should change some of the molecular properties? Having said that, you have all the time, even in this one, you have to go back and do in vitro testing, and you have to go back and, of course, do in vivo applications. Because it's one thing to do this in silico calculations. It might give us valuable information, but it will not be the end of the story. Hopefully, it will be the beginning of something which might be better. And that's the type of scenario I hope to set, that we will discuss molecular probes. What are the good things? What are the bad things? Or no, bad things don't exist, but what are things we should know more about? And I think the field is exactly in the scenario now that is needed. So Henry, I took my 21 slides, 20 minutes, and I look forward to the rest of the meeting. Thank you.
Well, I have the honor to introduce Carmen Dence. She is Associate Professor of Radiology and Radiological Chemistry and Imaging Lab at the Washington University in St. Louis School of Medicine. The Radiological Chemistry and Image Lab has a rich history of innovation. From the development of the first PET scanner to a pioneering work in radiochemistry and radiopharmaceuticals. The lab has shaped the leading minds in the field of molecular imaging. Professor Dence will lecture on PET as a biomarker in early cancer trials, FDG and beyond. Thank you very much.
Muy buenos días. Good morning, everyone. I'm extremely pleased to be here, to be coming back for the second time to this beautiful city, and it's always a pleasure, especially when living in St. Louis at 0 degrees. So yesterday, 3 hours around the Ramblas was enough to refresh my mind and body. So thank you again, Henry and Eduardo, for thinking about us. I acknowledge these investigators in my talk. How to evaluate the treatment response. So we have traditionally an anatomic measurement which can or the sequential scanning be too poor to really be reproducible. So an anatomic response is not expected to really give us answer for all the therapies. I bring 2 examples here, or what happened to the big farm when things just fall apart. And in this case, you will see here that the response to this particular inhibitor was practically very close to the placebo. And in the second example, let's see, another one big company, when one of their drugs failed in the phase 3, took a tremendous hit economically, and this happened in 2004, in which almost $7 billion were lost in 2 days when the results were made public. So results like these ones are the reason why we need to do better to monitor treatment with cancer. Clinically, we need to do that for better patient care, but also in drug development, there has to be a more efficient testing of new drugs. And this is where the guiding cancer therapy should be coming back with the imaging as a main goal. So here we have a staging, therapy, and the outcomes. The first goal will be the predicting tumor behavior. With the second, we want to identify targets, predict the response, and then to measure that response in a quantitative way. And underlying all of this, we have to elucidate the cancer biology that goes in tandem with what Professor Langström was saying. We need more than pretty pictures. So this cartoon specifies just some of the different radio tracers that chemists have been developed to understand better the biochemistry and what is going on at the molecular level. So FDG is great, and taking a step farther than FDG, we have this tracer here, and what is measured in United States, well, we know that we have this one approved along with fluoride and few more, but in general, very few of them. So an early assessment of treatment is important in any drug development issues. So we need to be concerned whether metabolic response criteria are needed for different cancers and different therapies. And we want to question whether the measurements that we do with PET are really sufficiently unreliable to be trusted for decision making. And those results really predict outcome of these very expensive trials. So despite many problems, PET is an attractive approach to assess response with target therapy. And this expression here, target therapy, is the underlying concern that we as scientists, in all of us at different level of participations, have to address. So why FDG? 95% of anything that we do involve FDG. Well, come back a long time ago with the Warburg effect, in which the differentiated tissue takes glucose, and if there is a small amount or the absence of oxygen, we go directly to the lactate with only 2 moles of ATP formed. And if we have enough oxygenation, then we have a very extensive oxidative phosphorylation producing lots and lots of energy through ATP. However, the proliferating tissue and tumor it won't discriminate before the presence or absence of glucose, and the anaerobic glucolysis, which is called the Warburg effect, is the basic principle why we use FDG. So to measure FDG uptake, there are many issues, of course. We have patient preparation, the timing, the imaging and acquisition and reconstruction. We have to define the regions or volumes of interest, quality control, and interinstitutional cross-calibration. So we are all familiar with the SUV, and remembering, of course, that the body weight is important on how the SUV is calculated. So the heavier the patient, of course, there is going to be a bias in the measurement, and the lean body mass have been suggested as being better than the standard SUV. So besides body weight, there are also other interventions. When was the injection done? How successful was the injection? If it's extravasated, there is going to be differences. The region of interest can be defined in many ways. The scanner calibration, the resolution, reconstruction, and also, of course, the normal markers in the blood, such as insulin levels, are also critically important. So for the core labs, so we need to use in vivo biomarker. There has to be really a well-site qualification and SOPs that timely assure that the data that we get is correct and that we can share that data with other centers within the school, within institutions, and across the world. So this is an example of a problem. When the scanner calibration was checked, it was found more than 12% incorrect. And so we need better ways to uniform the phantoms. And there were other problems identified, but this is pretty critical. And unless we do a better job taking details into account, we are going to have problem with the numbers that we get from the scanners. The applications of FDG in the cancer trials are very critical. We have phase 1 and phase 2, and we need those very important surrogate response marker to understand the cytostatic agent that we are administered to patients. However, the problems that we know happen with FDG, if the tumor is too small or with low metabolic activity, we are going to have problems discriminating and having problems with partial bolus effect, and these are some of the examples of tumors that fit that category. The pathological uptake is also non-specific. Inflammatory lesions are also a target for FDG. Benign tumors are also going to pick up FDG. And again, if these tumors can be happily living with the patient, then we need to spare that patient from extra treatments. So the new imaging goal is to match now the tumor biology with the therapy. And that implies that we need, in PET cancer imaging, systems or compounds that characterize the tumor biology pre-treatment, going back to what we are very fond of calling individualized specific therapy. But that response has to increase, and we need to minimize the side effect of the therapy administered to patients. We need to identify targets and predict the response, and we need to do all of that as early as possible. The new cancer agents are going to feel the need for, again, taking this uptake based upon a specific tumor biology, and they should be easily made in large quantities and be able to be distributed, such as we had with FDG. Clinically, practically, meaning clinically feasible imaging protocol and qualitative and quantitative interpretation so that the imaging analysis can be very robust and automated. And we have in this conference 2 great speakers that will address the quantification and preclinical issues before we get to this point. So the roles of PET specifically in breast cancer. So we know breast cancer is the leading cause of cancer-related mortalities among women all around the world. And 30 to 40% of these patients will develop eventually metastatic disease. There are some variants of breast cancer, such as the triple-negative cancer, which is associated with even higher incidence of recurrent distant metastasis and poor survival. But again, we need to cautiously identify who of this group of patients will actually go to the worst stage. So in breast cancer, we can consider whether the patient is estrogen receptor positive or negative, and depending on that state of definition, FDG with an estrogen challenge could be, of course, very well received. If there is an ER negative endocrine resistant breast tumor, then we need to monitor different signals and inhibitors of those signals to hopefully restore the estrogen receptor positivity. And this is because the disease may start with being ER positive, and throughout the course of the disease or throughout the course of the treatment, it will change to ER negative. So here, I believe the predicting response to this metabolic disease goes to, this was a study done by Professor Dadashti at our institution, and one important, very, very different response by the non-responder versus responders was the assimilation, the SUV change, and I will go back to this a little bit later. So, selecting breast cancer patients for endocrine therapy will fill that need, but how to identify these patients and how do they will benefit? So, the question is estrogen receptor the answer? These three structures that we have here are so far kind of the gold standard, the best imaging agent so far for the estrogen receptor, FES, the androgen receptor in prostate cancer, FDHT, and the progesterone receptor also during breast cancer, during therapy, FFMP. All of these are routinely made at our institution for one of the many studies that we do in breast cancer. Since 1987, the presence of FES in a primary breast cancer tumor was established. These are metastases in the chest, and this is the liver. And the tumor correlated very strongly with the estrogen receptor concentration. And now the big question is, how, again, we identify the hormone responsive through an imaging approach. So we get a drug here, there is a receptor that we hope is FES positive, the FES is administered. How do we measure that response? At the cellular level, we use FDG, and after a certain amount of therapy, then we will have a clinical outcome. This could be months, but it could be hopefully earlier than that. So the general FDG will be the general agent for tumor imaging because, again, we are measuring a surrogate, a hyperglycolytic tissue. How best to identify now these cancers and who will respond? So if we were going to be concerned with the presence of the probe for a receptor, we do one imaging, and if we want to identify the function of that ER receptor, that means the change in tumor after hormone challenge, then 2 images will be required. So we need to be sure that a test of function, if possible, will be more informative than a test of presence. And this is the crux in any disease in which receptors are involved. We are extremely happy and we want to know is present, is the target present, but is it functioning? And again, here we go back to the biochemistry of the tissue. This is a very nice example of an FES patient imaging of breast cancer, and the patient number 1 and number 2 being before tamoxifen, which is the drug usually used if the breast cancer is positive for ER, and this is after tamoxifen. So the SUV have a great decrease, and the therapeutic dose of tamoxifen has been able to block the estrogen receptor. So the next study was also done by some early investigators at Washington University, confirmed later. What it is here is showing how the ER concentration and the tumor uptake of FES corresponds very nicely with the non-PET gold standard immunohistochemistry. So, in summary for this part of the talk, we have, as I referred before, a so-called metabolic flare, and that was determined by serial FDG imaging after tamoxifen or estradiol. So we want now to do a single FDG. So the baseline has been established, and now we know that we have a more reliable predictor than just the tumor immunohistochemistry. So PET does appear to be an effective, non-invasive tool to subdivide ER plus patients into what type of endocrine therapy will be necessary and be able to discriminate between responders and non-responders. Switching back now to traces that commonly are used for proliferation, we have the nucleoside analogs and sigma-2 receptor ligands. Why is important for us to measure tumor proliferation? Tumor proliferation estimates the aggressiveness of a tumor, and it has very important effects in the outcome for chemo or radiotherapy. If the tumor is proliferating very rapidly, it will respond better to cell cycle agents and or hyperfractionated radiation therapy. And the change in proliferation can be used as an indicator of if the response positive to radiation chemotherapy. So one of the earliest traces, as all of you may know, was of course C11-thymidine, 1994, Mankov. Great advantages is a substrate for the salvage pathway, the TKN, and the S phase of the proliferating cell. And it is incorporated into the DNA through the S phase. The disadvantage, it was labeled with carbon-11, and it very rapidly metabolized into difficult, and it was then difficult to conduct kinetic modeling studies. The C11 labeled thymidine with carbon-11 gave way to the second labeling at the carbon-3 position by Shields in 1998, 4 years later to work out the FLT as we know it today. This is the second generation of thymidine analogs, and they have very many good advantages. These are incorporated into DNA because now instead of having the fluorine in the 3 position, we have changed it to fluorine in the 2 position, and they have still some disadvantage are phosphorylated via the salvage pathway and are especially measuring the TK1 activity. So we are questioning ourselves, is really the S-phase fraction the best method for imaging proliferation? And this is just a question that is up in the air because investigators like Bob Mack and many more have really strongly emphasized that perhaps the sigma-2 receptors are better tracers to measure proliferation, as we can do a ratio of quiescence versus active cell during proliferation. So, however, FLT as a tracer is very good for PET imaging of breast cancer, and this one, courtesy of Shields, is showing us very vividly the responder and the non-responder images of a patient after a very short time. So here, the FLT really immediately gave the answer that the physician, the nuclear physician wanted. And so for some cancers, such as lung cancer here, non-small, again, we have a very dramatic percentage decrease of the responder and the non-responder with a very high sensitivity and specificity. So in this study that I just showed, we have the drug administered at that ratio here, and only after 7 days of initiation of therapy, the change in HUV was significantly different, and after 6 weeks, it was completely well differentiated. So the conclusion by the author was that the FLT-PET can indeed predict the response to the drug in 7 days or less. And the change in the tumor SUV max obtained by FLT-PET seems to be a promising predicted variable for, in this case, cancer and the therapy. Hypoxia. Important also to understand and to consider. Any hypoxic component that is present in most solid tumor probably is going to be present in human tumors, not only in animal, but also in human. And the hypoxic element increase the local aggressiveness and the metastatic potential of this tumor. And it results in a resistance to radio and chemotherapy. So that means that we need to add more high radiation and probably try to compensate hypoxia by hyperbaric oxygenation, hyperthermia, or to add sensitizers that can transfer these cells to being to stop being hypoxia. But effectiveness may be limited by patient selection. So there are several different PET radio traces available to do just that and quantification. And this cartoon here illustrates very nicely first hypoxia less than 1,000 ppm and the fact that as the tumor becomes less and less able to get the oxygen needed, in this case, cells farther away from capillary feeding will be, this will be practically necrotic at the end, and they will increase, and they will decrease in the drug concentration that can assume. So consequences of hypoxia, we need, is related to the expressions of many genes, such as the VEG, and many genes responsible for resistance to chemotherapy. This is no work. Okay, here it is. We already said we'll increase the metastatic potential of this tumor and the aggressiveness at the same time. So the gold standard had been measuring hypoxia with F-MISO. F-MISO undergoes bioreduction, and if there is hypoxic tumor, enter the cell and remains within the cell, and is well characterized as a probe for hypoxic cells in vivo and in vitro, but it still have inadequate imaging characteristics such as insufficient tumor extraction, low lipophilicity, and it's very slow blood clearance, and this is this is one of the worst, poor target to background ratio between the hypoxic and the normoxic tissue is relatively low after 2 hours. So the new tracers developed to imaging hypoxia is really an alphabet of letters here, but the important thing is that many of these tracers, especially this FASA tracer, had displayed a hypoxia-specific uptake, which provided that very good tumor-to-background ratios and is superior to the standard hypoxia tracer, fluoromycin. So PET as a biomarker in early cancer treatment trials. This is a summary here, and we know, as has been stated many times, that the drug development is a complex, time-consuming, and very costly. More than 10, sometimes 15 years is taken before big pharma can take a drug from conception to the general public. And the cost can have been estimated to about 800 million. This price change, depending who you read, can be 5 to 7 and as high as almost 2 billion. And very bad, the current rate of failure in phase 3 is about 50% of a drug. And PET, we believe, with its inheriting quantitative sensitivity, is then ideally suited to help shorten that time and reduce the cost of the development. Okay, so let's see. So oncology beyond FDG, so it's driven by the goal of more individualized therapy, more specifically target and less toxic therapies, and definitely will be playing a big role in choosing what is being done with the patients and identify resistant factors to whatever therapy is conducted. And the better response monitoring will be the key to earlier measurement of treatment efficacy and more specific measures of drug action. So the quantitative endpoints of the clinical trials could depend on how well we apply PET to the care of our patients. So we do believe, and we are very optimistic, that the new tracers, the one that I have mentioned, and there's so many, many more that chemists have been able to concoct and try preclinically and clinically through phase 0 and exploratory INDs can ultimately be approved through a fast process and benefit all of us as we grow older. So when these drugs will be available in a general PET facility, the necessary components, again, are the commercial sponsorship, proprietary versus non-proprietary drugs. And this is critical here. So many of the drugs that we are developing are not patent protected, and that could be a problem if a company wants to invest money. They have to go through an FDA approval that will not be the same as for FDG. And it will have to follow traditional new drug application process and the defining reimbursable clinical indication, who is going to pay for that. In the United States, of course, if Medicare and Medicaid accept new drugs, these new drugs probably are going to be in a lot more use and approaching a lot more patients. So I thank you for your attention, and invite you to our campus, our beautiful city, but not in winter time. Thank you. Okay, so I'll close it.
Thank you very much, Dr. Carmen Dence, for your excellent lecture. It is so important that she say that the PET is not only a tool of diagnostic, it's also a tool to know the cancer who are responder or non-responder. And breast cancer, that this is one of the main cancers in Uruguay, is going to be very nice to have this kind of studies. I want to know, Dr. Dence, if you have some experience in inflammation with the FLT cancer, because we have only a few patients, that 2 or 3 patients that we did FLT images, and we have the problem that the adenopathies are very big uptake, high uptake, but they were inflammation. That is why. Yes.
Yeah. Okay.
Okay. I actually think this question will be better addressed by Dr. Alavi in his second talk, but definitely one inconvenience or limitation of FDG, which is the acquisition by inflammatory tissues or inflamed tissue, can be a beneficial effect depending how we look at it. So with FLT, I believe the main thrust, of course, is in proliferation, but that you will have to really do the dual trace study and use either one of the newer tracers for inflammation, which I didn't even mention, or go back to the standard FDG and then do a more discriminating quantitation and what is really driving the uptake.
Dr. Cuello?
Yes, I have a comment from an Uruguayan perspective, because in Uruguay, the frequency of triple negative breast cancer is higher than in other countries. And we don't know if it's real or it's a problem with immunohistochemistry. I think that these techniques could improve this problem, could solve this problem. And also could improve the time to therapy, because we get the information about receptors 1 or 2 months after the surgery. And time to therapy is a very important factor, prognosis factor in breast cancer. And I have a question. Do you have any experience with marker to HER2 expression?
I personally cannot address the HER2, but I know that yes, there are markers that will identify one of the triple negative. HER2 is one that can be absent along with the ER and the progestin receptors. So I cannot right now give you the name of a tracer, but certainly will be one that only in the specific cases of this triple negative cancer, which are fortunately a good percentage of the female problems are going to be, it has to be addressed by better trace technology.
I don't know if there is any question after in the public.
Thank you for the nice presentation, Carmen. I have a question. Do you have some experience using the hyperbaric camera to avoid the hypoxia issue of the treatment and
Right, to overcome hypoxia. Clinically, I know that has been used. I don't know if at our institution how frequently that's being used at with animals. Yes, has been certainly validated. Correct, do you know if the hyperbaric oxygenation had been part of any clinical protocol? I'm not very familiar. I know hyperthermia has been clinically in place and is commonly done at Washington University, but the hyperbaric, I tentatively will say clinically don't know of any particular case.
We have wait 4 hours to perform the PET study, 3 and 4 hours. And there is an increase 4 hours after the injections.
You mean clinically in patients?
Yes.
Okay.
Yes.
And you wait 4 hours?
Yes.
And you still cannot distinguish very well between tumor and background tissue?
Yes, 4 hours
Right.
before the injection.
Yes.
After the injection.
Yes, so that corroborates just the comment on one of my slides. The ratio between hypoxic and normoxic tissue is really pretty lousy. And so the new tracers, such as the FASTA, the arabinosil type, that definitely will be a better tracer. And we are making now, we make F-MISO, but in the exploratory IND, we are working more toward getting tracers like FASTA into preclinical and eventually is already in clinical use through our DRCs. Yeah. So yes, we have much better tracers than F-MISO.
Okay, thank you very much.
Mm-hmm.
Thank you very much, Dr. Carmen Dence. Well, I have now the honor to present Professor Abass Alavi. And as Dr. Henry Engler said, that in August 1976, he became the first to perform a human PET study of the brain and whole body using the radiotracer FDG. Over the course of his career, he has published over 1,000 papers. Alavi holds the position of Professor of Radiology at the Hospital of University of Pennsylvania, and he is Associate Director of the Center of the Study of Aging in the University of Pennsylvania. Professor Alavi will lecture on the revolutionary impact of FDG-PET imaging on the day-to-day practices of medicine. Thank you very much, Dr. Alavi.
Thank you, Graciela. It's a great pleasure to be here, and I would like to thank Professor Engler and the organizing committee for inviting me to come to this beautiful country. Of course, see a lot of my friends whom I've known for years. And also, it's a great pleasure to be in this open podium as my student, great student, Carlos Spiegel, who's going to be speaking at this meeting. This is one of the joys of my life, to go around the world and see my students being successful in so many countries around the world. So I really come to share the history of FDG, which I never ever expected to be as important as turned out to be. And this really is one of the things in life that, you know, something comes along and you, of course, have some vision of what it may turn out to be, but most of the time, definitely in medicine, we really don't succeed as much as some others are. Now, how this journey began, And where is it heading? We started looking at images of the glucose in the brain by technicolor radiography at Penn in collaboration with colleagues at NIH by a very distinguished scientist named Sokolov. And this was being done by labeling C14. Just do it. By labeling C14, as you see here on the, just if I can only, is this? Point, okay, it's better. So C14, which is a beta emitter, was labeled with deoxyglucose, injected to animals. This was ongoing work with our collaborators in neurology at Penn, injecting these animals and then sacrificing the animals in about an hour or two after injection of C14 deoxyglucose, and seeing, of course, uptake of the FDG in the cortex, less of it, like 25% of the cortex in the white matter. And in this particular animal, which was done at Penn, using activating the sensory cortex in this animal. This animal has like mustache, we call it whiskers, and whiskers are being brushed while the C14 deoxyglucose is circulating. As a response to the stimulation, we see this significant uptake of C14 deoxyglucose in the cortex. So when we saw these images, said this is really smiling at us to go to human being as fast as we can. So 3 of us at Penn, namely myself, David Kuhl, who is really a giant in the field of nuclear medicine, the pioneer in tomography, Mara Rivich, neurologist who was working with colleagues at NIH, sat down one day in a cold winter in Philadelphia, December 1973, said, we got to label the deoxyglucose with something that we can see from the outside. Of course, it was very clear to us that this had to be positron emitter, not technetium, not indium, but a positron emitter. So we called our chemist colleagues at Brookhaven National Laboratory. The head of the group was Al Wolf, and Joanna Powler, who was his assistant and a visiting scholar from Japan. So we went and discussed, and this eventually led to making FDG in Brookhaven National Laboratory, which is about 60 miles east of Manhattan, and then we are about 100 miles south of New York. So we had to fly this first dose from Long Island to Philadelphia, and then we had a medical student who was recruited for the experiment, another medical student to bring it from the airport to hospital where we are, and it's about 10-15 minutes ride, and he was speeding on the street, on the highway, but fortunately he was able to convince the officer to let him come to HOP, our university, and then I injected the first dose of FDG, the first human being, which we imaged with SPECT machine that we had at the time. So this is not a nice image, but this was a history-making image. And not only, of course, we were able to show cortex uptake and less uptake in white matter, but also even with this primitive approach, we were able to measure metabolic rates. This is milligrams per 100 gram per minute. So this was a very exciting day in our academic life, as well as medicine in general, as we have witnessed over the years. While I had this poor subject at my disposal, I said I should do the first whole body image as well. We had very small amount of FDG by the time it was delivered to us, no more than like 4 or 5 milligrams. So I made this image brick by brick, literally, because we had no other whole body imager at the time. So these are called rectilinear scanners that were really the first to develop in medicine for imaging. And so it took me 2 hours to take this image. But again, we showed the uptake in the head, uptake in the heart. Interestingly, we were not able to fool the kidney, but we were able to fool the brain. Every molecule of deoxyglucose, in contrast to glucose, goes all the way down to bladder. In contrast to glucose, that every molecule that is filtered through glomeruli is reabsorbed in the tubules. So this was a very important beginning. And thereafter, we actually got the scanner that Ted Pekosian, who truly is the pioneer, as was you, who had built this machine called PET-3, and was bought by us and Brookhaven National Laboratory jointly to put at Brookhaven because we didn't have a cyclotron at Penn. So every other week, I will take this team with me from Philadelphia to Brookhaven National Laboratory. This is actually me. I had a lot of hair at the time on top of my head, as you see there. And these are, of course, our colleagues. We're actually doing stimulation of the visual cortex. So I will take this team and have subjects in my own car driven to Brookhaven National Laboratory, and we'll make images, and every Monday I will come with Polaroid pictures of what we did in the preceding week. Now, FDG is an incredible agent just by luck that just allows us to do imaging with the instruments that we have. Because in contrast to glucose, which was done, say, for C11 glucose at Mallinckrodt by Mike Welsh, our very distinguished colleague, in which they just went through transporters and went through the pathways very rapidly. FDG, after phosphorylation to FDG6 phosphate, remains in the cell. And again, this is God's gift to us that doesn't go beyond that point, although I'm going to emphasize the importance of glucose 6-phosphatase because many of the issues that were discussed in the previous talk by Dr. Dence is also related to this glucose 6-phosphatase. But the fact is that we can have FDG locked in the cell for a long period of time, which allows us to image these patients, and delayed imaging, as it is a very, very important part of tumor biology and other elements that go with cancer. So this, of course, is the basic principle behind why FDG works as well as it does. As neuroscientists, as I was in most of the 70s and 80s and in parts of the 90s, we looked at almost every possible disease that you can imagine in brain. But when we went to Medicare for payment, as you heard, in 1985, they said, Dr. Alavi, you can diagnose every Alzheimer's disease with FDG. What can you do for them? I said, nothing. He says, come next year when you've got something to offer. That next year took us 20 years when cholinergic drugs were developed. Then the FDA and Medicare approved it for Alzheimer's disease. So it was very interesting from the point of science. For the first time, we are looking at brain function in a very vivid way. People were using xenon and other tracers, but it wasn't as powerful as having tomographic images that we were able to make with FDG. Then the best marriage for FDG became apparent at our institution at NIH, started looking at brain tumors. And this really was the beginning of what made PET succeed. Without this, PET would have been a research tool at WashU, at Penn, at Hopkins, and nowhere else. So a man named Warburg in 1930 described the glycolytic activity of tumor cells, which it was sitting in the literature. Nobody was using it until FDG became available. And this really saved PET as we know today. But as we started looking at whole body imaging, especially in the 90s, we realized that we have an offender, and the offender is inflammatory cells, either an infection or pure inflammation. And as I will show you, because part of my talk and also part of this talk later, you have to turn your enemies into becoming your friends. So this is really what we have done. We have said, this may be a problem when we're dealing with cancer, but we got to turn around this and make the best friend out of this so-called false positive results. Because atherosclerosis related to inflammation is becoming a huge thing right now for FDG, looking at muscles, either in the heart before bypass surgery or muscle dysfunction in any situation, and also clot detection. I believe that we're going to be looking at clots with FDG 5-10 years from now. We are not going to do spiral CT. We are not going to do anything fancy. So we're looking at 10 most common diseases of mankind that can be looked at with one tracer alone. Of course, as part of what you do with any text, whether it's blood test, whether it's imaging, you got to look at normal variation, effects of age. And this is really what we have done with every instrument that we have introduced to our laboratory. See really how normal brain looks like. So this is far cry from the first image that I did. Of course, going from the top of the head with modern machines. We can do the whole thing in 30 minutes, while it took me a long time to do slice by slice, which is what we had at the time. PET-3 that we had from Tepekosian did only one slice at a time. We can, of course, do quantification. As Dr. Dence mentioned, this is really the major asset of PET, quantified. No other imaging modality can quantify the way that we can quantify with PET. And of course, our early work was dealing with more sophisticated measurements than we are today. SUV has problems, but it's only way that we're going to be able to do quantification. But I had to do arterial line insertion, get the blood samples over time, and these are, of course, whole brain metabolic activity, and whether we like it or not, based on these data, showed that from age 20 to age 90, we are declining. Our metabolic activities is declining, therefore our brain function is declining. But there are those of us who want to retire at the age of 20. They are here, and there are those of us who are up here at the age of 80, 90, still active. So you got to choose your parents correctly to be up there, not down here. So this is, of course, a patient with Alzheimer's disease where we have decreased activity in the parietal lobes, temporal lobes. Of course, there's a lot of discussion around the world right now about new ways of diagnosing Alzheimer's disease. My maybe bias, maybe not, is that FDG still is the way to go because of its extraordinary sensitivity in detecting neuronal dysfunction, much easier than any other technique that we have, and it's really very specific. I think this is going to remain the way to go until we have figured out whether we can use other tracers. Because that's the beauty of PET, that is not only FDG. We have got hundreds of compounds, and the imagination of the chemists and scientists is really the limit, having capabilities around the world, having cyclotrons, attracting a lot of chemists to our field to do what can be done. So that I'm not against, but we have to be conscious of what is doable, what is not, and validate the technique. So FDG for Alzheimer's disease is now validated, and I, along with David, were the first to do these studies. And so it is well tested over the past 35 years. Now, for cancer, as was discussed, we can look at different phases of cancer. You know, breast cancer, as was discussed, is a very important area, and I really truly believe that we got to get rid of mammography. I don't think that MR is going to make it because it was very non-specific, very sensitive, very non-specific. So really, FDG-PET is going to play a major role in detecting cancer, and especially in really characterizing this very complicated cancer, as was discussed with regard to differentiation and lack of it. And again, FDG is going to be the centerpiece of looking at breast cancer, as I will just show you a few more slides. But we can stage the patient much better in a patient with lymphoma than we can with any other modality. PET-CT has been of great value, definitely for surgery, for radiation therapy, but even for day-to-day practice, being able to get these beautiful images of PET and CT combined has been a major bonus to expanding PET, and especially making people believe in what we are doing. You know, it was just very difficult for us to talk to a radiologist and tell them what we're seeing is true. They just didn't believe in it, or oncologists. So this has been a major contribution of hybrid imaging in general, and PET-CT in particular. So really, by using PET-CT, we are able to see the effects of treatment. This is a tumor called GIST, and Gleevec is a magical drug. Within a day or two, we're able to see that the machinery of the cells has been broken down as reflected by FDG and continue giving the drug while giving the wrong drug and immediately going to the right drug instead of waiting with CT, that this took like 2-3 months to see that the drug is not working. And these drugs are toxic, expensive, and therefore seeing effects of treatment within at least a week or two or a month is significantly better than seeing changes with CT, which takes 3, 4, 5 months. Radiation therapy is benefiting enormously by having PET-CT. It's an example of a case of lung cancer where the entire area was thought by radiologists to be tumor, but when we do FDG-PET, we realize that half of it is just collapse of the lung, atelectasis, the other half is active. This significantly minimizes radiation to the adjacent area. So this is because radiation therapies would have radiated the entire area, but after FDG-PET, only a fraction of the area is going to be radiated. So really, this is minimizing enormously some toxicity that's associated with radiation therapy. In our center, now every patient radiation therapy goes through a PET-CT. We have a specialized PET-CT machine for the radiation therapy department that uses routinely for these cases. So, and of course, I'll talk more about this in detail. We see these beautiful images of infection due to inflammatory cells in this tailbone, and of course, non-dangerous inflammation in the arch of the foot. And this unfortunately dictates amputation in these patients. But of course, diabetes in our country is an epidemic. We have about 30 million diabetics and other 30 million in just transition to becoming diabetic. Yeah. Similarly, we have a major issue now with aging-related disorders, including osteoarthritis, and a lot of prostheses are put in every year, 1 million in the United States. And unfortunately, they're as good as they are, give them new life, gets really complicated at times. There's painful prosthesis that could be due to loosening without infection or due to infection. So this diagnosis of infection has been a big problem. And because if you have got infection and you go to the OR, you're going to have a lot of difficulties. And really, FDG looks great compared to white cell imaging, which requires 24-hour imaging, bone marrow imaging. So this is tomographic, and you just see these fantastic images as, you know, just showing evidence for infection. We've become very interested, as I said earlier, in atherosclerosis. Especially, we believe that the two curves, namely uptake curve that goes up like this, blood clearance like this, is very important for both cancer as well as other disorders. And definitely in the case of plaques, the longer you wait, the better you're going to see the plaques. So this is just fantastic plaques in the aortic arch going on. So this is really becoming a revolutionary technique for diagnosing as well as seeing the response to treatment. You know, we have like 7 statins in the market. Every one of them works differently from the other. So individualizing, as was discussed earlier, of treatment is going to be a must in the future. And PET is going to be the centerpiece. No question in my mind that this is going to be the way to go. To give the drug, within a month, you're going to see that these plaques that are here disappearing, we can quantify it and continue if it is working, and stop the drug and move to something else. Inflammatory disorders of any kind, so beautifully see here. As I said, we are very interested in clot detection. We're doing this with Paul Fleming, who unfortunately couldn't come to this meeting in Denmark. And again, I just don't think that we have to look at the lung to see the clots. We got to see the clots where they are, and therefore, we just are going to push this to have a multi-center trial in the United States, similar to what we have done in the past with PET studies, and use FDG-PET to see presence of clot, and also specificity is very important. Ultrasound is not good enough for this purpose. The question was raised about non-specificity of the FDG, which I totally agree. And this is where our friend glucose 6-phosphatase plays a major role. In cancer cells, we have no glucose 6-phosphatase, or very little, or the levels of glucose 6-phosphatase does exactly what was brought up about low-level malignancy, high-level malignancy. So if you have got very bad malignancy, triple negative breast cancer, you're going to have a very steep rise of FDG uptake will continue. But inflammatory cells have a lot of glucose 6-phosphatase, so FDG uptake, which is definitely related to high glycolytic activity of these cells, but soon, around an hour or two, you're going to see disappearance of the FDG from the cells because FDG is separated from phosphate and has to leave the cell. And therefore, if I do an image in 1 hour and 90 minutes or 2 hours, I will see a different pattern. Cancer will go up, inflammatory cells will go down. So this is just an example of a cancer in a study that's 60 minutes and 90 minutes. This is actually a bad cancer because the amount that is going up is very, very significant. You know, we've shown with our data, and I've done studies up to 8 hours during Saturdays, shown that tumor to liver ratio goes up extremely high. You know, in 1 hour, you have almost 1/3 of what you have in 4 hours. So we are not using FDG properly. Everybody's doing 60-minute image, and that has to stop. We have to move to 2 hours, even possibly to 3 hours. And of course, one reason that this happens also in the liver is that the liver has a lot of glucose 6-phosphatase, so it gets rid of FDG 6-phosphate fast, so one curve goes up, tumor goes up, and liver goes down. You know, we have looked at 1, 2, 3 hours activity in every organ. You know, you see this, our friend liver is significantly losing its activity over time. Interestingly, some tissues, of course, go up, and that's heart and bone marrow. I didn't know that until we started the study several years ago, and of course, this shows behavior. In most places, we lose some activity over time, which helps us in having better contrast between the lesion and the background. So these are left ventricle, it's going up, and bone marrow is going up, because these are two efficient tissues that we got to keep going. This is pushing the blood against high blood pressure that we have, and therefore has to use glucose very effectively. This is, of course, bone marrow in order for us to keep going with our red cells in the blood, with our white cells and platelets. So bone marrow is very much like cancer cells. These are just showing the importance of delayed imaging. It's a patient lung cancer with pleural effusion, and there's a little metastasis that I can just see in the center here that I didn't see in 1 hour, but I'm seeing in delayed imaging. Again, the slope of primary is very important. We see more metastasis over time than in early images. Of course, this is a patient who has metastasis to adrenal gland that I did not see early on in 45 minutes while I saw. So this patient should not go to surgery. We should eliminate at least 10–15% of the patients by showing evidence for metastasis, therefore not to send everybody to surgery, which unfortunately doesn't cure. Unfortunately, cancer, as I will mention later, is a moving target, cannot be cured because of inhomogeneity of cancer. Related to breast, again, this is the type of thing that we see with this so-called dual time point imaging. Patients with highly differentiated tumors with estrogen progesterone receptors have very low uptake of FDG and change very little over time, like 4.5%. This is a triple negative patients. I've got like 2 or 3 times more metabolism and changed significantly from one image to the other. And every one of these patients had metastasis. These are based on 350 patients that we studied, and none of these patients had a metastasis. This clearly shows that pathologists have been misleading us based on really gross structure, which I think should go away in medicine in general, whether it's in the hands of radiologists or pathologists, because they just call everything cancer, and the surgeons, when they hear the word cancer, they're going to mutilate their patients. So these patients, in my view, should not be subjected to a lot of interventions, taking a lot of lymph nodes, causing lymphedema, giving radiation therapy afterwards. So this is a changing practice of medicine, tumor biology-wise. Was muscle activity? This is a patient with emphysema who's trying to get the air out of his lung and cannot do it successfully. So he's using all the muscles, including the abdominal muscles, to get these up. Because as an internist, I had seen these patients that they take air in, but it takes them a long time to get rid of the air up their lungs. So vividly, we've seen this. Of course, we want to see what exercise is the best for the patients in looking at whole body assessment, which is something that I'm going to discuss. What will be the best exercise to use most glucose? So this is related to it. We believe that PET lends itself just significantly to global disease assessment. Given 10 numbers to a clinician, SUV of 5, SUV of 3, SUV of 9, is very confusing in the same patient. So we actually came up with the idea in 1993. I was doing it for separating Alzheimer's from age-matched controls, and I realized that if I use the volume of the brain by MRI, and a very sophisticated segmentation technique, and measure whole brain metabolism, I can separate in a patient much better than I can. See, there's something. Okay. So this has been a very important part, and I'm going to discuss this further later. I don't know what this is happening. Because we have been looking at atherosclerosis, we call it atheroburden, using structure and metabolism. Again, whether we like it or not, and you see these numbers are very high. They are not SUV of 3, 5. These are the whole aorta metabolism, and showing that we are just having atherosclerosis as we age. Because we use sophisticated segmentation technique. This is very important for partial volume correction. We cannot just put a region of interest anywhere, not realizing that there's water, there's white matter, gray matter, all mixing together, the same thing in the lung. And this is really going to change in the future. I'm using a slide that the late Mike Welch from WashU gave me, and I modified it a little bit. And so there is life beyond FDG, and I'm very happy as a scientist to see that. In fact, I'd like to see more of it. So they are, as we hear, they're looking at DNA synthesis, hypoxia of various agents. Actually, this is PEN compound in injury therapy, which we were heavily involved in seeing gene transfer, thymidine kinase, because even our old friend, sodium fluoride, is coming back after being away for 30 years. Because PET MRI is going to be important, especially for domains that MRI is very important, namely brain, orthopedics, and cardiac areas. And what really has kept PET in an active and undo everybody else, definitely MR. This was a terrible coincidence of introducing NMR spectroscopy to human studies, and of course going to imaging, they call it MR, so that there won't be no nuclear, used to be nuclear spectroscopy, NMR spectroscopy. And it was very clear that at the time, this was, at Penn, we were very active in this domain, and I will be arguing, I was a young scientist trying to really, try to convince these established scientists that MR contrast agents are not going to make it because the low sensitivity of MR, at least 1,000 times, and more likely like 10,000 times. This killed MRI as a major competitor with PET. You just cannot give enough of these agents without toxicity. you actually can kill a patient with fluorine-19 labeled deoxyglucose because you have to give like 20 grams, 30 grams to get enough signals. So this was our favor. Finally, I just want to show you, of course, how PET became invisible to Dalai Lama. He came to visit us in early 90s, just 92, to see how we can look at the brain, you know, in various states, especially meditation. So this is really him, and I'm describing to him what we're doing with activation of the brain. Of course, this is a very famous scientist, Britton Chance, who was NMR spectroscopist, and he was to fight with me that he's going to win. And finally, within 10, 15 years of PET, he just came to me and said, no, you're right. And he moved into optical imaging, which really, at the age of 75, and that really, you know, just revolutionized imaging in other ways. So history is very, very important. And thank you for listening to my talk.
Thank you very much, Professor Alavi. It's fantastic, excellent lecture. I don't know if something in the audience that want to say something to Dr. Alavi. Okay.
Beautiful talk. So in that, one of the images you showed earlier with the FDG hotspot and to identify the tumors that for the surgeon to take out. There's a whole in the literature, there's all this discussion about heterogeneity of tumors and how different markers could label different areas of a tumor. So why could one area of the tumor take up FDG, whereas the other part could be taking up something different tracer, for example, if we had one, but the overall tumor will still be a tumor as opposed to one part active versus the other part not active. Is that?
But I think really what we are learning with FDG is that we have been too simplistic about cancer. Cancer is a very, very complicated process. Even within the primate, you see different areas, especially when I do you know, this early and delayed imaging. There are parts of the tumors that go up and parts of the tumor remain stable. Definitely, we're seeing significant differences between the primary and metastatic sites. So this just shows you tumor, metabolism is different, you know, just constantly is changing. Genetics of the cells is constantly changing. And that's why when it's not that we don't have good drugs. We have got great drugs, but they only kill 80% of the cells that are sensitive to that drug. The 20% that have changed their clothes, that become different type of cells, they no longer respond to treatment. So this is why we were successful with infections, because bacteria are very simple organisms. So when you've got a streptococcus in your throat and goes to your lymph node, goes to your heart, it still is streptococcus. So you can just treat penicillin and kill them everywhere. But cancer cells are not, and this is why PET is becoming so important in showing you tumor biology, how truly tumors behave that we weren't aware of. As I said, pathologist gets a very small sample of the tumor, and based on the small sample, extrapolates to what's happening in the entire body. While we have the entire body at our disposal that we can look at. So really, you know, as I said, it's just FDG is probably the most successful molecule ever in medicine in bringing up so many important, complicated issues that we weren't aware of. And of course, there will be other tracers that will add more dimensions to what we can do with PET.
Well, thank you very much.
You're welcome. Thank you.
Asuntos Públicos. Para conocer mejor, para saber más.